Greetings, my name is Lindsay Ma, and I'm a rising intern in internal medicine. Today we'll be covering osteoarthritis, the most common form of arthritis. Patients can be asymptomatic with only radiographic findings. However, other patients experience joint pain that is debilitating and worsens other aspects of their lives. This may partly explain why osteoarthritis is the third most common principal diagnosis at admission in 2018. So let's discuss how to diagnose and manage osteoarthritis on the inpatient side. The target audience for this talk is clerkship level medical students, so let's see what we can learn today. First off, OA is a clinical diagnosis, so no tests are actually required, and rather, an assessment of 3 items can help you confidently make a clinical diagnosis. What might those be? Well, the first would be persistent usage-related joint pain. The second is age greater than 45 years old, and morning stiffness that is less than 30 minutes. Thinking specifically about joints, let's think through what joints are most often affected. This image from UpToDate can be super helpful, and I think it's best to group the joints into 2 categories. The first being weight-bearing, and the second being non-weight-bearing. Those weight-bearing joints are kind of in the middle here, and the non-weight-bearing ones being in the hands. So what are some of the weight-bearing joints that we think of? Very commonly, hips and knees, but patients will also complain of pain in their cervical spine and lumbar spine. As for non-weight-bearing joints that are involved, we can think about the joints we use very often and bear the most torque. Those would be our MCP joints, like at the base of the finger here. Imagine how often you're using your thumb on a day-to-day basis, as well as DIP joints primarily. So these ones all being DIP joints or distal. There are some other joints involved as well. An example, MTPs, metatarsal, but here's a general overview of the joints that are involved. So going back to our clinical assessment, there might be some other symptoms that increase your suspicion of osteoarthritis. What might those be? Compared to some other illnesses, osteoarthritis tends to have a pretty slow progression, but this isn't specific. And there tends to be swelling, but we know this is not specific as well. Deformities may occur, but are also non-specific. And then we want to make sure that they do not have constitutional symptoms like fever, chills, night sweats, and then joint warmth also should not be present if the patient only has osteoarthritis. Of note, these are not sensitive or specific. And that's why we really focus on these 3 clinical assessment items. What if your patient has some other symptoms that make you worry about a different diagnosis? And what might those diagnoses be? In our differential, we should probably include things like rheumatoid arthritis, infection, gout, psoriasis, hemochromatosis, soft tissue malignancies, and even fractures. To rule out some of these things, you might end up getting some other tests. That might include fluid aspirations, imaging like MRI, blood tests, such as testing for rheumatoid factor, etc. However, these tests are not necessary in order to achieve a diagnosis of osteoarthritis. One test that is very common, though, and can help us identify radiographic findings of osteoarthritis would be an X-ray. And that X-ray might occur because you're looking for radiographic findings of arthritis, Or you might have had a different reason that you're getting the x-ray, and maybe findings of osteoarthritis are just incidental. What would those findings of osteoarthritis be? Typically, we're thinking about osteophytes as well as cartilage loss. The issue with these again are that they are nonspecific. In other words, these can be found in other conditions, not just osteoarthritis. And that's why I want to go back to the important point that osteoarthritis is a clinical diagnosis, and that even if you have these radiographic findings, if you do not have a clinical assessment that matches osteoarthritis, you're not able to diagnose osteoarthritis, and rather you have to look for a different diagnosis. However, let's say that this clinical assessment is pretty compelling for osteoarthritis and that you're able to make that diagnosis. Then we'll have to think about how to manage these patients. Management goals for osteoarthritis are to minimize pain and slow further damage. While inpatient, though, we will focus on minimizing pain and optimizing their pain regimen. Pain management can be split into non-pharmacologic and pharmacologic methods. We typically want to prioritize non-pharmacologic methods first, since they tend to come with fewer side effects. While in the hospital, these things can include getting a PT-OT eval, and they can help recommend things like walking aids, knee braces, and splints, which can be really helpful for the thumbs. Sometimes non-pharmacologic methods are insufficient to manage pain, or if the patient is coming in due to an osteoarthritis flare, then the benefits that come from these non-pharmacologic methods may not be effective fast enough to help the patient. So we can add pharmacologic methods to the non-pharmacologic methods to get a better effect. The current first line for medication management of osteoarthritis would be topical NSAIDs. That would include things like Voltaren gel. These are really effective if only a few joints are involved, and we aren't as worried about some of the common NSAID side effects when they are applied topically. If topical NSAIDs are insufficient for the patient's pain management, or too many joints are involved such that it's not practical for the patient to be applying these topical medications, then we'd want to consider oral NSAIDs. And this would be instead of topical NSAIDs. Current data is limited on the use of concomitant topical and PO NSAIDs, and so we don't know for certain how beneficial using both of them would be or what the side effects might entail. Oral NSAIDs can be a very effective pain management method because it acts on the inflammation that is often a source of pain for these patients. However, there are many contraindications to NSAID use, such as GI bleeding or history of GI ulcers. You can mitigate this risk some by co-prescribing a proton pump inhibitor, but bleeding risk is still a concern. Furthermore, if a patient is on blood thinners or has certain other cardiac diagnoses, NSAIDs may be contraindicated. Furthermore, kidney injury is common with NSAID use, and so many of our patients are unable to use oral NSAIDs as a management method for their osteoarthritis. Some things that you can consider if the pain is more neuropathic and the patient describes symptoms like burning would be duloxetine. This is an excellent SNRI that can be an adjunct to the NSAIDs that the patient may be using, or be used by itself if NSAIDs are not an option for patients. Duloxetine can also have a dual benefit by helping with mood, since many of our osteoarthritis patients have comorbid depression and anxiety. Lastly, topical capsaicin can be used by patients in a similar way to topical NSAIDs. This could be a great option for patients who have few joint involvement. However, some people find the capsaicin, which comes from a spicy pepper plant, to cause more discomfort on the skin that outweighs the benefits they might get of pain management within their joints. I also wanted to touch on a few pharmacologic methods that have been tried in the past but are no longer recommended. The first would be Tylenol. Typically, we see this as a pretty benign medication to give, but there have been studies that demonstrate Tylenol is ineffective in managing pain when targeting osteoarthritis. So, despite the relatively low side effect profile of Tylenol, we have to remember the possible liver damage that can occur with overuse of Tylenol. So, Tylenol is no longer recommended as first line or part of any of the osteoarthritis pharmacologic management. Opioids have also been used for osteoarthritis pain management and may have a role in the acute setting. So, if a patient has a flare, for example, and is coming into the hospital for that, potentially there might be a role for opioids on the short term. However, this is not a recommended strategy for long-term outpatient management. Lastly, steroid shots or injections into the joint space have been used and provide some short-lived benefits. However, these are not recommended due to evidence of injury to the hyaline cartilage and the possibility to accelerate osteoarthritis progression. Two items that we won't go into detail today are surgery as an option for patients who did not derive sufficient pain relief from pharmacologic and non-pharmacologic interventions. Modifiable factors that can be addressed outpatient include regular exercise, weight loss, and mood management. All right, so to summarize, osteoarthritis is a clinical diagnosis. If you have these three items, you can pretty confidently diagnose osteoarthritis. Radiographic findings suggestive of osteoarthritis, including osteophytes and cartilage loss, are nonspecific. You might find these because you are getting an x-ray for another reason, but if the patient is asymptomatic, we would not diagnose them with osteoarthritis. Furthermore, the degree of severity identified on x-ray correlates poorly with clinical symptoms. So, management should be adjusted based off of clinical symptoms and not radiographic findings. Some notable management points include non-pharmacologic methods such as getting walking aids, knee braces, and splints. NSAIDs are the mainstay for pharmacologic management of osteoarthritis, but not every patient can safely take NSAIDs, so you can also consider duloxetine and topical capsaicin. Tylenol, opioids, and steroid shots have been historically used for osteoarthritis but are not recommended. Your time is precious, so thanks again for joining me for this talk. Until next time.